We're delighted to have Dr. Matt Phillips here to present this year's Brain Tumour Awareness Month webinar. Matt is a clinical and research neurologist at Waikato Hospital in Hamilton. His foremost passion is to explore the potential feasibility, safety, and efficacy of metabolic strategies, particularly fasting and ketogenic diets, and creating alternate metabolic states that may benefit people with a variety of neurological disorders. His team conducted the world's first randomized studies in people with Parkinson's and Alzheimer's, and he's currently conducting a clinical trial that combines intensive fasting with a ketogenic diet alongside standard treatments in patients with glioblastoma. So, Matt, welcome, and over to you.
Thank you, Chris. And thank you, Vicky. I'll just share my screen here. So my name's Matthew Phillips. I'm a neurologist in Hamilton, New Zealand, as was mentioned. I'm originally Canadian, so hence the accent. The talk is named Metabolic Therapy in Glioblastoma. And for the next 30 to 40 minutes, I'm just going to talk about a program that we've been running here in the Waikato region for at least, close to 2 years now for people with glioblastoma. Okay, so we're going to start with something called germ theory. Now, germ theory is a few hundred years old, and it was championed by Louis Pasteur, who was a French chemist and microbiologist who, to be honest, I really looked up to as a kid. Now, germ theory is a disease-centric theory. It basically states in simplified form that pathogens like bacteria and viruses are the origin of disease. So if you want to help someone with a disease process, you have to target and eliminate the pathogens. And this really does focus on elimination, this theory. A nice example would be antibiotics to treat people with bacterial infections. There was an alternative theory way back when, a couple hundred years ago in the 1800s, at the time, and this was called terrain theory. And not too many people know about terrain theory. I'm sure some of you do, though. This was championed by a man named Antoine Béchamp, who was not just a scientist, but also a medical doctor. And he was a contemporary of Pasteur's. He was actually a little bit older. And they sparred verbally often over decades with respect to their theories. Now, this theory was a more health-centric theory. It recognized that, of course, pathogens existed, but it viewed most of them as scavengers that really, most of them could only instigate disease in a weakened host. And so Béchamp viewed a fundamental dysfunction in the tissues and cells as the main problem with these disease processes. And this implicated, rather than trying to eliminate the scavengers, the best treatment strategy here was to restore the tissues and cells, or the terrain, or the health of the body. And so his focus was on restoration, but unfortunately, at the time, he didn't really have a very good target. We were identifying lots of microbes, and Pasteur had good targets for his vaccines and so on. But Béchamp didn't have those. So he ended up making recommendations like get sunlight and exercise and so on, but it was a little bit vague. So at the end of the day, he lost the debate, and germ theory won. And germ theory now pervades, I would say, most of what we do in medicine. So if we look at standard treatments in glioblastoma, the current standard of care is the Stoop protocol. This involves surgery. So you resect the tumor to an extent that is feasible. You have to avoid vital areas, of course. You give radiation 5 days a week for 6 weeks, and then you give chemotherapy 7 days a week for 6 weeks. And you do this in 5-day cycles every 4 weeks. So sort of 1 week on, 3 weeks off kind of thing. The Stoop protocol essentially, and I'm thinking, just think broad brushstroke, think broadly here. It treats cancers as a sort of infection based on germ theory. It aims to eliminate the cancer cells. And it is really, there's nothing about restoring the health of the body in the STIP protocol, really, other than indirectly through the elimination of cancer cells. However, we're offering a metabolic therapy program, and this is a clinical trial, so it's highly experimental, of course, but many people here would know that there has been some work in fasting and ketogenic diets in all kinds of cancers in other parts of the world. So what this metabolic therapy program, or MTP, is we're adding it as an adjunct, or I should say in combination or conjunction to the STOOP protocol. So it's tailored to work with the STOOP protocol. And this involves prolonged fasts, which are serial 5-day fasts, and they're strictly timed with the standard treatments. And I'll show you why, and how they're timed and why they're timed that way. And we also involve intermittent fasting, which is just smaller fasts. So eating 1 or 2 meals a day on all of the days. Some days it's 1 meal, some days it's 2. And we sort of give a program as to when to eat 1 and when to eat 2. And when people aren't doing the big prolonged fasts, they're eating a modified keto diet. So every time they're doing the intermittent fasting, it's not just intermittent fasting, it's also a modified keto diet or ketogenic diet, which is very high in fat with adequate protein and very low carbohydrate. And so the MTP is based on terrain theory. It aims to weaken the cancer cells, but importantly, it also aims to protect and restore the normal cells. I believe this is a very important thing that we need to do as well. So you can see, I guess we're trying to combine Pasteur with Béchamp. We're not favoring one over the other. It's the combination that I believe may yield the greatest success. And that's the rationale, basic rationale for the trial. Now, I am going to talk a little bit more about fasting and keto diets for the people that don't know much about this. Prolonged fasts, or any fasting really, is a voluntary abstinence from food and drink for specific periods of time, usually 2 to 21 days for a prolonged fast. Anything over 2 days is really considered prolonged, up to 3 weeks. Now, you can take it a lot longer than 3 weeks, and I've spoken to some people that have done this. The world record, I often say this, is well over a year. It's 380 something days, but that's sort of extreme. Now, on these fasts, you need water and salt, so they can be done as just a water and salt fast, or you can do it by adding in some tea or maybe some coffee, best just a bit of black coffee and not too much. And some people do fasts with a tiny daily meal. There's a sort of calorie restricted fasts. That's viable. So you can really do fasting many different ways. It's not just water or, just water and salt. Now, fasting, most importantly, should be seen as a method. It's just a way to establish therapeutic ketosis. Now, ketosis is where the body has these energy molecules running all over the place throughout the blood and the tissues, called ketones. And ketones come from body fat, primarily when you're fasting. And ketones have a number of benefits that I'll talk about in a few slides for your normal cells, particularly your brain and neurons and your muscle cells. Fasting can be done, in terms of how frequently you do it and for how long. The prolonged fast can be done anything over 2 days, but I think going on basically a lot of what I've read and through self-experimentation, I got to say as well, I believe the 5-day fast may be optimal for at least glioblastoma. I might be wrong there, but this is the time course I've chosen for the trial. And of course, they can be much longer. You can do these for weeks or months if you want to, but I'm not sure that is necessarily beneficial. Now, intermittent fasting is shorter version fasting. So this is something you can do every day. You obviously can't do a prolonged fast every day, infinite for indefinitely. You have to eat at some point. But intermittent fasting can be done every day for sort of 12 to 48 hours, well, 12 to 23 hours if it's daily. And this can be water only. You don't have to supplement with salt. Salt is needed in those longer ones to maintain your blood pressure, but you don't have to have the salt in these shorter fasts, and you can still throw in some tea or some coffee. This is also a method. It's a less intense method for establishing ketosis, but the advantage of this one is you can do it really over the long term on a daily basis. And the way intermittent fasting is done is several ways, of course. You can do time-restricted feeding, so you fast for, say, 16 hours a day and you eat in an 8-hour window, or 18 and 6, or any variation you want. You can do 1 meal a day. That's also known as OMAD. So you have a 23-hour fasting window and maybe 1 hour to eat.
Oh, good.
Or you can do two meals a day. I guess I call that TMAD. And that's a variable window. You can sort of, the way I sort of prescribe that is by allowing people to sort of choose the time of the day when they want to eat the 2 meals, as long as they eat them within an hour.
Immediately.
Now, a keto diet is a diet that's, and I put this in yellow just because it's so often missed. It's very high in fat. Okay, it's adequate in protein and very low in carbs. So a lot of people, restaurants in particular, when they advertise keto food, get the fact that you need to be very low in carbohydrate, typically under 50 grams a day, but you also have to increase the fat tremendously. And that's where a lot of people go wrong with the keto diet, I find. It's best seen as a method as well. So it's better seen as a method like fasting rather than as a diet. It's a method for establishing ketosis, or a strategy, or I've called it a strategy in the past, for establishing ketosis, whereby you generate ketones, not from so much from the body, but from dietary fat. So it's from the food. And this can be done multiple ways. So long as ketosis is achieved, it can be omnivore, carnivore, vegetarian. It doesn't really matter too much to me. I've had patients on all of those regimes. As long as you achieve ketosis, that's the main thing. And it can be many different ethnic cuisines. It can be variable in dairy. I find that some people can tolerate high dairy and some people can't. That's okay. You can do any of those, I find, as long as ketosis is achieved. And also it can be high fiber, low fiber, or no fiber. That's okay. Like some people, if they do the carnivore keto diet, for example, it's really hard to get fiber in there, and that's okay. Whereas if you're doing a vegetarian keto diet, it's going to be it really should be very high in fiber. And I've had people do that, and that's okay too. So it's not about which diet is best. They're all methods trying to achieve ketosis. Okay, so now that you understand a bit more about the fasting and keto diet side of things, at least from my perspective, we'll look at more at metabolic therapy. So how could metabolic therapy, such as our metabolic therapy program, or MTP, help people with GBM? Okay, there's a few mechanisms. And this is one of the great things about this plan, this therapy program, is that it doesn't just sort of make life difficult for our tumor cells from one angle. It hits it from multiple angles. So first of all, the MTP lowers blood glucose while raising blood ketones. Now, this is really important because glucose is the predominant fuel for GBM cells by far. They can probably metabolize at least one amino acid, glutamine, which is the most abundant versatile amino acid in the body. And that ultimately comes from protein. And maybe they can also metabolize some others, such as methionine. However, it's really glucose that the majority of tumor cells in the majority of cancers, but particularly GBM, that they rely on that. Now, at the same time, it raises blood ketones, which they have a difficult time using for energy if they can use it at all. And so what we're trying to do here is lower the blood glucose and raise the ketones to lower this thing called the glucose ketone index, or GKI. That is the ratio of glucose in the blood to ketones in the blood. So what you want is lower glucose in the blood, so less fuel for the cancer, higher ketones in the blood. So you swamp them with these energy molecules that they probably can't utilize efficiently, if at all. I'll talk more about that in a couple slides as well. Now, the second way the program works is it actually augments the resistance of the normal cells to conventional treatments. When you have a chemo or radiation or any stress coming in, normal cells will hunker down and stop dividing and focus on survival. Whereas cancer cells don't do this. So normal cells undergo differential stress resistance, or DSR. They become more resistant to these stressors, such, particularly the standard treatments. At the same time, you augment the sensitivity of the cancer cells to those treatments because you're depriving them of their main fuels. So you induce at the same time differential stress sensitivity, or DSS. So I hope you can see that this creates an environment that's beneficial for normal cells, but hostile to cancer cells. The third thing, and this is where I sort of take it a little further than most people in the field, I suppose. I believe that this is a very terrain-based concept. I believe that the fasting keto diet fundamentally restore health, which I define as the health of one's mitochondria. Mitochondria are these little sort of batteries, that people call them batteries, that exist in almost all cells, and basically keep the cells going. They do a lot more than just make energy, though, for the cells. They do a lot of other things. And basically, this might be a way, if you're restoring the health of all the normal cells, then this might be a great way to prevent recurrences. Now, I'm speculating there, but at the end of the day, there's no point destroying a tumor if you are also hurting the normal cells around it and producing damage and to their mitochondria and to their genes that might induce them to become tumors a couple of years later. So you have to think of the long game in these cancers, and that's what point 3 is about. Point 4 and point 5, these are just a couple extra things if you're interested. That the metabolic therapy program might induce these, we call these epigenetic alterations. So epigenetics is just how the genetic code is read. So you have a fixed genetic code, but parts of it are sort of turned on, parts of it are turned off at any one time. And the metabolic therapies, there's some evidence that they will allow it to be read in a way that does not favor the cancer state. And they may activate the immune system. And that's a very enticing concept as well. I'm not going to get into that one too much in this talk, but it's there. Now, we're going to go through the first 3 mechanisms in a bit more detail. So first of all, lowering glucose and raising the ketones. So the MTP, Metabolic Therapy Program, lowers the GKI, glucose ketone index. And that makes life difficult for cancer cells by depriving them of glucose, as I mentioned. That's their dominant fuel source. These cells upregulate their glucose intake by 10 to 100 times. It is tremendous. And so they're far more susceptible to a sort of choke. If you lower the glucose, they're far more susceptible to that than normal cells. At the same time, you're swamping all the cells with ketones, cancer cells and normal cells. And this is a better fuel source for the amount of oxygen a person breathes. Ketones make more energy than glucose. And there's really very limited evidence, and none of it good, if you ask me, that cancer cells, including glioblastoma cells, can utilize ketones for cell growth. Now, there are some animal studies and a number of xenograft studies where they transplant cancer cells onto animals. And then there's there's a little bit of speculation and inferential thinking behind some of these studies that maybe cancer cells can use ketones to grow and survive. There is no good evidence in any study, to my knowledge, that cancer cells can utilize ketones over glutamine and glucose and all these other things to survive and proliferate. Okay, now that is a general statement, but we have to think in terms of generalities here. If we think too much about, maybe in this case, that case, this cell can use that, then I think you end up getting confused because nothing's going to work at all. But at the end of the day, this is a very important concept, that ketones are not a viable fuel source for cancer cells to grow and proliferate. Now, if we look at what this means, here's the glucose on the left y-axis, so the far left bar going down, and then we have blood ketones on the right. Now, what most people run on day to day, because we're eating a 3 meal a day standard Western diet, which has a fair bit of carbohydrate in it, or even if you're don't have that much carbohydrate, it's still going to be similar to this. The ketones, the black bar, are sort of around 6, and the glucose, the black bar, my bad, are around 6, and the ketones, the red bar, sort of rests in the negligible level, around 0.2 or 0.3, shown by the red bar there. And when you do the apply a metabolic therapy, that trend is sort of it's altered or sometimes reversed. Now the y-axis they've shown there are a little different. The glucose and ketone y-axis is not quite the same, so it sort of makes it look like the ketones are way higher than the glucose when you get onto a metabolic program. But it really, a good metabolic program would have the ketones sort of half the glucose level, or maybe even approaching the glucose level, so around the same. That would be a really good program. But that's the sort of zone of managed growth that one wants to achieve, where life is difficult for cancer cells. And so the ideal GKI in humans is not known, but lower is better. And at least in animals, less than 6. seems to lead to reduced brain tumor volumes and better survival. Now, less than 6 is not that low, but it's, even that level, 5 or 6, you start to see effects. Now, at the same time, metabolic therapies augment conventional treatment. So what we're trying to do is induce differential stress resistance and sensitization. So we're trying to make the normal cells more resistant to chemotherapy and radiation and make the cancer cells more sensitive. So in animals, this does happen. So the metabolic therapy program induces normal cells to enter a stress-resistant mode, making them resilient to radiation and chemo, and they have fewer adverse effects from those treatments. And due to the nutrient deprivation, the cancer cells are more sensitive to radiation and chemo, so their elimination may be enhanced. So don't look at these diagrams too much. There's a lot of stuff in there, but normal cells undergo a lot of metabolic changes, shown by all the arrows in there, that enhance their resistance to chemo and radiation. Cancer cells don't do that. They rely on their original metabolic changes that tell them to grow, grow, grow. So they don't stop, they just keep growing, and yet it's hard because they don't have much fuel. So evidence in animals does show that fasting sensitizes cancers, including gliomas, to radiation and chemo, and it prolongs survival. Okay, what about restoring mitochondrial function, the third point? So the nutrient, this is, there's evidence to back this up as well, but it is also theoretical. It's all theoretical with some evidence. The nutrient deprivation promotes mitohormesis, whereby the mitochondria become sort of more resilient in the long run. So you stress them a little bit. The fasting and keto diet are stresses, so that's why they can be a little hard at the start. But with time, as a person gets used to them, the mitochondria adapt and they become more robust, and function improves. It also lessens mitochondria exposure to oxidative stress. So fasting and keto diets reduce oxidative stress, which might reduce damage to mitochondria, and it promotes mitogenesis. So fasting does this quite powerfully. Mitochondria need to be able to move around and fuse together and then divide. And by doing this, they are able to allow new mitochondria to be sort of born and old junky mitochondria to be recycled and removed. And this is an extremely important process that we don't really allow our bodies to enter in too much on a 3 meals a day eating pattern plus snacks. So the fasting, I think, is the real power behind this concept. So the basic concept is, again, you've got a damaged mitochondria, very simple diagrams, and you're trying to make them healthier. Okay, so perhaps by restoring mitochondrial function, we can knock down some of those recurrences. So what is the evidence for metabolic therapy cancer? Until now, we've sort of been discussing animal studies, and now I'm just gonna present human data. Okay, nothing to do with mice. There have been 7 interventional studies, to my knowledge, that have used fasting with standard treatments in advanced cancer in people. Now, collectively, this is any cancer, not just GBM. Collectively, they show that fasting improves the quality of life, improves adverse effects, and enhances the differential stress resistance, the resilience of the normal cells to the standard treatments. There have been quite a few interventional studies that have explored ketogenic diets. Interventional study just means a group of people had an intervention applied, in this case, a keto diet or a fast. Now, the interventional studies involving keto diets in conjunction with standard treatments collectively show that the diets improve quality of life. That's fairly firm, and which is contrary to what a lot of people might think, I guess. And same with the fasting, that you have to, you can't eat much, and you have to eat a lot of fat. Actually, quality of life fairly robustly improves in both. And the keto diets may prolong survival. I don't think the evidence is that great, and the effect is very small if it's there, but it's probably there. And the trouble is we lack randomized, really good clinical trials and randomized controlled trials in this area. Okay, what about glioblastoma in particular? So looking at human data only, there's only been 2 interventional studies, unbelievably, that have looked at fasting with standard treatments in glioblastoma. One, the picture there shows one that we did, was published last year. Now, the first study only did a single 3-day fast, and that was basically it. So it was very, very limited fasting. The one we did there involved a series of sort of 6-day fasts on average over 5 to 6 months. So it was more rigorous. But both the studies were, and I include our own, were difficult to interpret because in the first case, the fasts were limited. In the second case, our patients were very far past their diagnosis, and most of them had sort of completed their standard treatments, so months and months past their diagnosis. So we weren't able to overlap and combine the fasts with the standard treatments, which to me, is the crucial element that we're talking about here, combining Pasteur with Béchamp, or germ theory with terrain theory. There have been about 10 or more interventional studies that have looked at keto diets with standard treatments in GBM. And these were difficult to interpret as well, because most of them were very short, less than 12 weeks. And only 2 of them that I could see measured the GKI. So if you don't measure that, you don't know how powerful the keto diet is, right? You don't know how much pressure it's exerting. So that's the data in GBM in humans. It's quite limited, I guess. Now, what we're doing is we're trying to make, of course, the best and most rigorous study out there, at least to date. So we've designed a comprehensive metabolic therapy program for people with GBM that combines fasting and a keto diet with standard treatments. Now it involves prolonged fast. So we're doing serial 5-day fasts. This is what our patients are doing in this trial. The fasts are strictly timed with the standard treatments to exert maximal pressure when the chemo and radiation are given. Think of this as a pulse. It's like a brief pulse for a few days of powerful treatment against the tumor cells and powerful protective influence for the normal cells. When they're not doing the prolonged fast, though, the participants in our trial are always doing intermittent fasting. So they're eating 1 or 2 meals a day on all the other days. And this is sort of a press. So you're chronically exerting pressure against the tumor cells and chronically trying to restore the health of the normal cells when you're not doing the big fasts. And of course, during intermittent fasting, all they eat is the modified keto diet. That's it. It's very high in fat, adequate protein, low in carb, and this exerts metabolic pressure too. But I think the keto diet is a weaker press. I often liken fasting to Batman and the keto diet to Robin in our programs. I believe fasting is the power. At least this is the way I'm conceiving of it, and this is the way our metabolic program is designed. The keto diet is not the power of the program. Now, our objectives are, we have to do this. Feasibility, is it doable? Because, these are people with glioblastoma, and, we're asking them to do a significant lifestyle change. Is it safe? And that's what a lot of medical doctors obviously worry about. And most importantly, I think this is probably the most important one for people with GBM, quite frankly, is it efficacious? Does it work? Does it help improve quality of life, survival? I'm going to give you a look at the protocol here in the last 10 minutes. The metabolic therapy program basically represents, this is an important concept, it is the most intensive metabolic therapy that has ever been applied to a group of people with any advanced cancer, not just glioblastoma. And it's applied for a minimum of 9 months, okay, during all the chemo radiation and adjuvant chemotherapy. That works out to be about 9 months. So what happens here is a person with GBM is, of course, diagnosed with a biopsy, and then they have resection of the tumor. Now, not all our participants, some people are unlucky, and the tumor is so deep or in such a vital structure, it cannot be surgically resected. And we have 25% of our, actually close to 30% of the people in the program are that, inoperable. Okay, so we are taking some of the most difficult, and I should say, we're only taking IDH negative, the sort of wild type glioblastomas, no astrocytomas. And so we're really trying to keep it to the hardest of the hard here. We're taking the most, the glioblastomas with the sort of worst prognosis. Now we apply, or I should say the oncologists apply after the surgery, chemoradiation. So as I mentioned, the chemotherapy and radiation combined for 6 weeks. Some people get less, but the patients in our trial get 6. And during that time, we start participants on a 5-day fast 3 to 4 days before they start the chemoradiation. Now, the reason for this is to, after 3 days, your glucose is pretty low of fasting, your glucose is low, your ketones are pretty high, and so we get people maximally protected and maximally hostile environment for the tumor before the chemoradiation starts. So we want people, we hit hard right from the start with this program, super hard. Okay, so we're making life real difficult for the tumor cells, and the normal cells are protected. Then we hit with chemo and radiation. So I hope you can appreciate that this is a real super intense approach, not just with the standard treatments, with the metabolic program. Now, after they do that first 5-day fast, 2.5 weeks later, they do another. This is a second hit. And the idea is you sort of, I'll use colloquial language, I guess, that you've got the tumor on the ropes potentially, and now you hit it again with a second 5-day fast. 2.5 weeks is not a lot of recovery time, but we're finding that it is enough. After the chemo radiation, there's a 4-week break where there's no chemo radiation, and the people just do their 1 or 2 meal a day ketogenic diet. Then there's the adjuvant chemotherapy, which is 6 months. So for the chemotherapy that's given, as I said before, 5-day cycles, so daily for 5 days, and then nothing for just over 3 weeks, and then another 5-day cycle. So first would be cycle 1, then cycle 2, cycle 3, and so on, up to cycle 6. Every time there's a cycle, before the chemo is given, 3 to 4 days before the chemo is given, guess what we do? Yes, we start another 5-day fast. So we're trying to get the body, the glucose low, the ketones high, and sort of the tumor maximally stressed metabolically before the chemo hits again. And of course, the normal cells are maximally protected as well. And we do that 6 times over 6 months. So there's a lot of pressure. And afterwards, technically, the standard treatments for most people are done at this point, but and this is where I give everyone who gets out here. We have 5, arguably, because there's a pilot patient who have completed all their standard treatments, and ask them, well, what do you want to do? This is what I'd recommend. We probably should, if you want to keep exerting pressure, particularly if you're doing well, and all the people out this far are doing well. If you want to have done well, if you want to keep exerting pressure, you might want to keep up the intermittent fasting and the keto diet, but perhaps just forego the 5-day fast. And so everyone basically is still doing that, and they're still measuring their ketones, and I'm still reviewing them every 2 months. That's the program in a nutshell, and it's registered there at that URL on the internet if you want to look at it again, or you can just look at this talk again, I guess. Now, in terms of feasibility, I'll just give you a little bit of preliminary data. I can't give too much because the trial is, of course, we're only halfway through. But basically, everyone is measuring their blood glucose and ketones daily during the standard treatments and afterwards indefinitely, as I mentioned. So this is what it's looking like for the first 9 to 10 months. So during chemoradiation and adjuvant chemotherapy, the blue bars are the glucose, the red bars are the ketones, and I've made them all on the same axis, so it doesn't look a bit exaggerated like that other chart I showed you did. So what you can see here is at baseline, the mean blood glucose before they start the metabolic program, everyone's got a blood glucose of just over 6, and the ketones are negligible, about 0.3. And I gotta say, 2 or 3 of the participants started a sort of a weaker version of a keto diet before they entered, because they were enthusiastic. So that's okay. But probably the ketones would have been even lower if it wasn't for that. But anyways, 0.3. And you can see in chemoradiation there, the left 2 bars, red and blue, are weeks 1 to 3. The right 2 are weeks 4 to 6. You can see that the glucose drops down. It doesn't look like a huge drop, but that's a decent drop down into the high 4s. And the ketones go up quite a bit, so 2.5 or so. So the ketones are about half the level of the glucose level. And for the rest of the 9 to 10 months, the participants are maintaining a very good glucose level and a very good ketone level. So you can see they're sustaining this. This is almost up to a year. And to my knowledge, this kind of metabolic pressure has not really been shown in a group of people. Case reports, one person reports it has, but not in groups of people in the literature. Now, what does this mean? If we look at the GKI, that glucose ketone index, which is really the important variable, at baseline, the GKI is close to 20. So that means, the glucose of 6 and the ketones of 0.3, 6 divided by 0.3 or so, you've got something close to 20. So it's a terribly high GKI. And that is basically, if this metabolic theory is correct, that is a cancer-loving state. Okay, there's glucose everywhere, and there's very little ketones. Now, if we look at chemoradiation, once people start the metabolic program, the GKI falls to 2. Now, 2, remember, less than 6 in animals is efficacious against tumors. 2 is pretty darn good. And, I really give a lot of the credit to the participants here. They're just very disciplined and adherent and dedicated to the program. And over the 9 to 10 months, absolutely up to a year almost here, it's staying within the 2 to 3 range. So they're maintaining a strong GKI. During the 5-day fast, I should also mention, it even is more powerful than this, because during those 5-day fasts, the mean GKI, I've calculated it, it's about 1. So during this, all these bars are shown here, but within here, we have these pulses where the GKI is really choked off, reduced down to 1, and hopefully that's helping these people do good things for their bodies and not so good things for the tumors. What I want to say here is, collectively in this trial, the participants are sustaining the therapeutic GKI so far. We only have 11 patients that have enrolled in the trial, I should mention, and we're aiming for about 25. But so, we have half the numbers. It's preliminary data, and it could change, but so far it's looking very, very promising. In terms of safety, we are measuring adverse effects using this well-validated sort of adverse effect form that all the oncologists use, called the CTCAE. It's an acronym, common terminology in cancer adverse events. So we're assessing any and all adverse effects, and the oncologists are actually doing this as well. So it's combined between the oncologist and myself, regardless of where they come from, but the standard treatments, the metabolic program, or if the people are unsure. And then there's a second questionnaire that I'm administering, for a more focused checklist that says, if there was a side effect that the CTCAE identified, is it from the standard treatments, the metabolic program, neither, unsure, trying to figure out what's the source of the adverse effect to the best of our ability. Oncologists, people in trials with drugs often get excited when you don't have an adverse effect. If it's a 1, 2, or a 3, grade 1, 2, or 3, that's seen as pretty good. We've had nothing over grade 2. So all the adverse attributed to the metabolic therapy. There have been 3 or 4 attributed to the standard treatments, low platelet counts and white cell counts mainly, nothing too sinister, but that have been grade 3 or grade 4. Nothing to do the metabolic program. And this is over a long period of time now. Our pilot patient is at 2.5 years now. Okay, I haven't mentioned that, but our pilot patient is at 2.5 years. The first person in the trial is at about 20 months. Nothing's been over grade 2. Lastly, I'm going to talk about body weight changes, because a lot of people do worry about this. So if we look at the body weight changes in these 11 patients over 9 to 10 months, almost a year on this highly intensive metabolic program, you can see that people are losing about 10% of their body weight, and it's not dropping below that. Now, unintentional weight loss is a problem in people with cancer because it indicates malnutrition and ongoing muscle loss. But intentional weight loss, if you look at the literature, and in the setting of a properly applied metabolic program, a metabolic therapy program with fasting and keto diets done properly, you get mainly, almost exclusively, fat loss as the source of the weight loss. And the muscles are largely spared. Okay, there is a little bit of muscle loss, but with all the fat loss, we find people's function often improves because they got less weight, proportionally more muscle than they had, because they've lost a lot of weight, but almost all of it's fat. And even though they've lost a tiny bit of muscle, there's so much less body weight there, they can actually do more. So, and also if you look at the literature, intentional weight loss, such as gastric banding procedures and so on, where they force weight loss through surgical methods, those people have a lowered risk of developing many types of cancer. So intentional, what I'm trying to get across here is unintentional weight loss is undeniably bad, but all the weight loss in this trial is intentional. And we're also looking at body mass index. This is the last slide on the prelim, second last, or BMI. Now, if we look at the BMI over 9 to 10 months, people that started the program were overweight. 25 to 30 BMI is overweight range. 30 plus is obese range. Now, after 9 to 10 months, the average person, most people are normal weight, and they're actually still high normal. Their BMI is around 24, which is good. Normal is 20 to 25. But, even though you could argue losing a little bit more would still be, not a problem. They still be in the normal range. Now, given the nature of the metabolic program, which is largely a fasting protocol, this is absolutely not surprising. It would be expected. And logically, you could argue, and I would favor this, the normalized BMI could be perceived as ideal, right? We're trying to improve the health of these people. Part of a healthy body involves being a normal weight. So intentional weight loss, getting people in normal weight range, I would argue is a good thing. Okay, now efficacy. This is, of course, what is most important to people with GBM. Now, we are looking at changes in function, like performance status. We are looking at changes in exercise activity. We are looking at changes in quality of life. And we are looking at, of course, perhaps the most important thing, overall survival effect. And I am sorry, I'm not going to give the data at this talk. It is far too early. And I think it would be a bit irresponsible of me to give the data. I don't want to get people's hopes up and then have things change, because I respect glioblastoma for what it is. It can look like it's very tame and quiescent, and suddenly it can, sort of go get really aggressive. So I hope that if I give a similar talk in 6 or 12 months, that I can start showing some data. But probably, with scientific research, one should try not to speculate too much ahead of the data. And I've already given some data on feasibility and safety that I think is reasonably sound, and I don't think it's going to change, but it could. So I apologize for not giving you evidence on whether it's affecting these 4 efficacy things. However, I guess I would say we wouldn't still be doing the trial if we weren't seeing some positive changes. I'll just leave it at that. In conclusion, standard treatments in cancer are based on germ theory. Germ theory aims to eliminate the cancer cells, whereas metabolic therapies are based on terrain theory. This is a hugely important concept that we do not teach in medical school. We focus almost exclusively on germ theory related treatments. Metabolic therapy, based on the terrain theory concept, aims to weaken cancer cells and protect and restore the normal cells, which I believe is just as important as taking out the tumor cells. These approaches are not exclusive. Okay, so the application of standard treatments in conjunction with metabolic therapy, it is my belief that this may yield the best outcomes in people with cancer. Now, I may be wrong here, guys. However, I do think we can improve on the current Stoop protocol and the standard of care, and maybe it doesn't involve a totally different treatment, but complementing that protocol with something like this that can sort of mitigate the damage of the Stoop protocol to the normal cells and even enhance its effects against cancer. We are applying a highly intensive metabolic therapy program in conjunction with the standard treatments for people with GBM. And although our preliminary data is indicating feasibility and safety, we got to be cautious about that even. I cannot comment with any degree of strong rigor with respect to efficacy. We need more time, we need more patients. Fortunately, another hospital, Wellington Hospital, I'm hoping, looks like it may be joining us in the next couple of months. We'll see how that goes. But that's it for my talk, and I'm really happy to answer any questions.
Well, Matt, thank you for that. That was absolutely fascinating and a great talk. Now, I think Vicky's vigorously monitoring the chat box because I've seen some activity there, so there's bound to be plenty of questions. Have you got any from the chat box, Vicky? Maybe while you're doing that, maybe I'll ask a couple of the questions that we received earlier. I think you may have covered this, Matt, but in terms of when to start the program, what's the optimum start point? Do they need to start it at the chemo radiation phase, or do you think people can still do the diet after they've finished treatment and it could still be of use?
Yeah, it's, the trouble is with that, Chris, is once the standard treatments have gone on for 2 or 3 months, I guess if this theory, if I'm looking at it correctly, then we've already done a fair bit of damage to the tumor, but also to the normal cells. And applying metabolic therapy later, obviously, you've got more damage that you're trying to mitigate. And so it's ideal, I think, to start it, as I said, before the standard treatments, the first fast, starting 3 to 4 days before the standard treatments, to get people in that mode where it's hostile to cancer and protective for normal cells. And then you just maintain that mode in a pulse press fashion for the next few months and hope, potentially years. So I think earlier is better. But again, this is theoretical and a little bit speculatory on my part, but that's what we're doing.
Yeah. No, I can see that. I can understand that. Vicky, is there anything from the
So
chat?
there's the question about how can we use the MTP after we've survived the standard protocol phase? This is someone who's talking about 2 years post-operative and standard protocol with clear scans. I've been using keto diet throughout, haven't not been fasting.
Okay, well, first of all, congratulations. That's great that you're using the keto diet. So, when we get to this point when people have done this 9 to 10 months of standard treatments, and then we sit down and we go, well, what next? Because often the oncologists just sort of follow them with serial scans, but don't have any more treatments to offer. I guess my recommendation is that ideally, if you want to keep the body healthy, keep the brain terrain healthy, and sort of prevent those recurrences, because that's the big fear. If you've done a great job on that primary tumor, you don't want a recurrence. Then it's best to maintain your metabolic program. Now, if you're having great success with the keto diet alone, by all means, just keep doing that. I guess my idea is that from the research I've looked at, the keto diet alone in most people is not sufficient to prevent recurrences. It's good to slow growth and maybe stall it for a bit, but I don't think it prevents recurrences in many people. And that's why I like to throw in the fasting as well. And we're in an evidence-free zone there with the sort of long-term 1 or 2 meal a day fasting with keto diet. That's, combining these treatments. Often people look at fasting or a keto diet. We're looking at both. So we're not just combining standard treatments with a metabolic program. We're also using a mixed metabolic program to try and hit the tumors and restore health multiple angles. Hope that answers the question.
There's another question on whether you think this program would improve healthy brain cell production and cell regeneration in post-ischemic stroke survivors.
Oh, well, that's a good question.
Mm.
Yeah, it might. So if you look at this, again, I have to go back to animal data because this has not been looked at much at all. But when investigators induced strokes in mice, like they cause a stroke on purpose, mice that were in ketosis for a few days beforehand, like fasted, for example, they have strokes or infarcts. A stroke is a dead area of brain tissue from lack of blood supply, lack of oxygen. Their final stroke is about half the size or less than the stroke that was applied to the animal that was not in ketosis. So that's direct evidence that being in ketosis makes the stroke much smaller. Now, in terms of having a stroke and then applying a fasting or keto diet strategy after the fact, nobody knows if you can enhance regeneration of neural tissue and so on. There is neuroregeneration in human adult brains throughout life, but it's only in a couple areas. It's very small. So what happens in strokes is more that normal neurons around the strokes take over for the dead cells rather than regeneration filling in the dead cells.
Thank you. I don't know if you've had any information on this, but someone's asking about, is there any data on people who don't want to do the chemo radiation, but just want to do the metabolic program?
Awesome question.
Mm.
Oh, boy. Is there data on that? Not too much to my knowledge. I mean, there are case reports. We published one, for example, 4 years ago, but it was not in glioblastoma. It was in a metastatic cancer, a very bad one, a thymoma. And this young lady did no chemo, no radiation, no surgery. She couldn't have any of that stuff because she was deemed palliative and offered palliative chemo, which she refused. She did a similar protocol to the metabolic therapy program. And this is, created some of my inspiration for doing it in people with GBM. She did a 7-day fast every 1 to 2 months and a keto diet in between. And she's, I saw her last week with her husband and her little girl, 6 years now, after being given 1 year to live. And she's full quality of life, looking really good. So, but that's an exception, and that's a different tumor. So I'm not sure that this would be, I've had one guy who did fasting keto only, without chemo radiation in GBM. And, I don't think he had any enhanced survival. This was a few years ago. He didn't do the keto diet very well, though. He tended to focus a lot on the desserts, which had a lot of sweeteners. And so I learned from that and decided that our metabolic therapy program can't have very much sweetener in it because that has bad effects too. So there's not much evidence at all. And I guess my thoughts would be maybe a even stronger metabolic program that focuses hard on glutamine, hard on methionine, and all these other things could be helpful in people who don't get the chemo radiation. But for some of these big tumors and inoperable tumors, I think there's a lot of aggressive cells that you need to hit with the standard treatments at the same time.
Matt, can I just ask a follow-on from that? You mentioned glutamine and methionine. Are those levels enhanced by the ketogenic diet?
Well, nobody knows the answer to that, really. One thought is that, we have 2 or 3 people who, typically younger men prefer the carnivore keto option because it's easy and you completely choke all glucose, right? Because you're just eating steak and chicken and things like that. And you're putting it in some coconut oil or animal fat or something like that. It's possible that they do. I guess by focusing more on the fasting aspect of the metabolic therapy. So again, our program focuses more on the fasting. Maybe that can have beneficial effects against excessive amounts of amino acids that could potentially be a fuel for tumor cells. But it's really important to always think big picture, I think, with these things. I think if I can point something out, that in the literature, a lot of scientists really focus on one molecule or one amino acid or one thing. And I'm trying to look at things, I really try to look at things in the bigger picture. And I think glucose is by far the dominant fuel. And then by far number 2 is glutamine, by far. So if you're focusing on the dominant fuel and maybe hurting glutamine a bit, you're probably doing a pretty good job against GBM metabolism. Would it be ideal to choke all the other things? Sure. However, it's hard to get glutamine blockers. There are drugs that block glutamine. I don't know how to even get them, to be honest. And I'm in contact with Professor Thomas Seyfried semi-regularly, who is kind of like the leading guy in this. And anyways, yeah, so you're trying to focus on the forest and not worry too much about the trees, I think, with these programs. Otherwise, you'll just go crazy and it'll be hard to design anything.
I've got a question. So people who've got high cholesterol and have been on statins, how do they go about going on a ketogenic diet?
Yeah, so in a program, we've got a couple people with heart attacks in the past, statins. It's not a problem. Okay. And I realize that is a controversial statement. However, there's no evidence, zero evidence, that keto diets or fasting, of course, are in any way causative for heart attacks and strokes. And I'm a neurologist. I see ischemic strokes all the time. So what is the problem is the standard Western diet is highly correlated, which has, remember, there's so much confusion in the literature. So the standard Western diet is 30% fat, 50% carb, on average, 20% protein. That is high fat and high carb. Now, when you make carb, so by energy intake, our diet has sort of 75, 80% fat, maybe 15% protein and 5% carb. So when you augment one of the macros, but choke another one, I think that is a very healthy thing, because the mitochondria only have to metabolize one thing mainly. And conversely, not in cancer, but in other settings, high carb, as long as it's good carb with fiber, and low fat can be good too. For that reason, if people's mitochondria only have to focus on metabolizing carb and they don't have to worry about a huge influx of fat, that can be okay too. The problem is when you try to, mitochondria are damaged, I think very much so, by constant meals throughout the day where it's high fat and high carb. We call this a metabolic gridlock. They're trying to metabolize both pathways at the same time. They can't renew themselves. It's terrible state for mitochondria. And I think that is bad for cancer, and that is bad for heart disease and so on. So I think you know, I will say that I've had people on keto diets and fasting protocols for a number of years now, never had any kind of cardiac problem, a heart attack, anything like that occur on a therapy. But it is controversial. I agree.
Yeah. Someone's asking about patients with diabetes as well. Where's that one gone? Does the pathway work well for them?
Oh, well, we've had a couple people with pre-diabetes in the trial. Their pre-diabetes gets better quite quickly. I've had people in our Alzheimer's and Parkinson's studies with type 1 and type 2 diabetes. Type 2 diabetes, quite frankly, goes into remission quite quickly. And this was just on a keto diet alone, never mind the fasting.
Yeah.
Type 1 diabetes improves too. You just got to be a little more careful with them, because as they go along, they're going to have to use less insulin because they don't need it as much. So look, there's actually scores of studies in the literature in people, randomized trials, good studies that show type 2 diabetes is put into remission or at least severely improved on fasting and ketogenic diet protocols. That is, for some reason, still unknown by a lot of people, and doctors included, but it is absolutely true. And I don't even look at that anymore, because it's fairly rock solid to me. I've seen enough type 2 diabetes go into remission. I'm not even trying to do that. I'm trying to improve the Alzheimer's or something else, right? And so I keep an eye on the diabetes, but that it goes down is absolutely no surprise to me. And but it is a surprise to some colleagues. I remember a neurologist colleague of mine a few months ago didn't know this, and he was amazed. And I was amazed that he was amazed. But there you go.
I think a lot of people are interested in joining the clinical trial.
Oh.
So,
well, I would love to have
good to hear that
join.
Wellington might be doing something similar then. Yes,
the oncologists in Wellington were great. I gave a talk a few months ago, and they approached me, and they're very interested. So we've done the ethics, most of the ethical requirements, and I hope that we get them on site soon, and we can start enrolling people in that region.
Matt, there's a question about dexamethasone. Are any of your patients in the trial on dexamethasone, and were they allowed onto the trial? And how do they go in terms of their glucose ketone ratios?
Yeah, excellent question. So dexamethasone is a steroid that is often used in glioblastoma to reduce swelling around the tumor, because the swelling itself can make people have neurological problems, weak arm, weak leg, seizures, and so on. So dexamethasone is often given to reduce the swelling. It's quite effective at that. The trouble with dexamethasone is metabolically, it's good short term, because it makes people's quality, function better, bad long term. What dexamethasone does is it raises glucose and drops ketones, unfortunately. And so you don't want to have high dexamethasone doses for very long periods of time in a metabolic program. Now, that being said, I allow up to 4 milligrams daily of dexamethasone for people entering the trial, as long as it's on a reducing dose, and the oncologists are all well aware of this. And the dexamethasone, after that, if people have, often people are getting a treatment effect. So sometimes on a scan, a glioblastoma looks a little bigger, but it's actually a lot of it's swollen and dead, and we call that a treatment effect. It's quite common. We see that in standard treatments alone too. And a treatment effect where the tumor gets a little bigger before it gets smaller can produce problems, including swelling. So the oncologist might want to prescribe higher doses of dex. That's fine. I find that it does affect the glucose levels. It does increase them. It does drop the ketones, but not that much. And they don't need to be on steroids that long. So I was definitely worried of that a couple of years ago, but I'm not as worried about it anymore. It's not ideal, but it's not the end of the world if people have to go on 8 milligrams of dex for a little while.
Okay, great. Have there any other questions there, Vicky? Otherwise, we're after 8:30, and we were scheduled to go to 8:30. So I think there may be a few more questions. I'll save the chat box and perhaps pose those to Matt afterwards, and maybe we can work out how to get some answers to them. But just the number of questions and messages in the chat box are reflective of the interest in the topic. And Matt, I think it was an excellent presentation. Thank you for taking the time out to present to us and also to answer all the questions that you have.
Well, thank you very much for the opportunity, and I'll keep you posted on how we go.